Okay, we're
now live.
Okay. Good evening, dear doctors and honorable guests. I am Ahmed Salah, product manager, and now we are together witnessing the opening of the virtual international conference sponsored by Farco Pharmaceutical Industries. It's my great pleasure to welcome all professors who honor to us with supervising this scientific meeting, and we hope that cooperation will continue in the near future. And now we'll start the scientific day, but before that, we must thank dear Professor Dr. Yahya Salah, who donates his time and efforts to organize and supervise this special scientific day. Thank you, Dr. Yahya, and welcome to all international speakers in this scientific meeting. We wish a fruitful meeting, inshallah. Thank you, Dr.
okay, thank you, Dr. Ahmed. We will start the webinar about subluxated cataracts and intraocular lenses, and I'm going to just make a brief introduction. Of course, for the people who does not need introduction, Dr. Samuel Muscat, founder of Advanced Vision Care Center, LA, professor of ophthalmology, Stein Eye Institute, UCLA University, recognized as one of the most influential ophthalmologists, past president of American Society of Cataract and Refractive Surgery, author of more than 100 scientific articles and 2 textbooks, founder of Samuel and Barbara Muscat Foundation, which cares for the needy people, developed surgical instruments and methods used worldwide, holds US patents intraocular lens designs, and there are a lot of, he's a great person, great teacher, great friend, and we are really honored that he dedicated his time to be with us. Thank you, Dr. Samuel, for being with us. And we have the star Vladimir Pfeiffer. Dr. Vladimir Pfeiffer is the CEO of the Osensi Kuroski Center, professor of Ljubljana University Medical Center, Slovenia, president of Slovenian Society of Cataract and Refractive Surgery, past board member of the ACRS, the only ophthalmologist in Slovenia performing complicated anterior segment surgery, and he gets referred for all these complicated cases. He has tens of publications, has great innovative input in cataract surgery. Always he thinks of new techniques and instruments, and globally recognized eye surgeon and lecturer. And last, it's me, professor of ophthalmology in Cairo University and the president of Egyptian Society of Keratoconus and Corneal Transplant, past board member of Egyptian Society of Ophthalmology and Egyptian Society of Cataract Refractive Surgery, author of the first book about phacoemulsification as an Arab author, international lecturer and partner in Perry Project for Prevention of Blindness as a corporate social responsibility. So we are going to speak today about interesting, important, a lot of debates in this topic, which is subluxated cataracts, subluxated lenses, and intraocular lenses as well. So it can be for various causes that we're going to see, and we will see a lot of cases and we'll discuss about it and how to manage it. And intraocular lenses can put us in situations that we have to deal with them, so we should know how to deal with them. So there are so many scenarios, so many plans of management. So we are going to start with Professor Samuel Muscat, who is going to talk now about his experience in these topics. Professor Muscat, you can share your screen. You can unmute yourself, Dr. Muscat. Unmute. Okay. You are still muted. Ahmed, can you unmute? Sarah? Okay.
Okay. Okay. I will send him. Okay.
Am I unmuted now?
Yeah, perfect.
Okay, good. All right, sorry for the little delay. Well, first of all, thank you, Professor Yahya. It's wonderful to be with old friends. So both you and Vladimir are dear friends of mine. Not only are you wonderful teachers and innovators, but you're wonderful human beings. So it's really a great pleasure to be with you people. And a welcome to all the people who are listening to this presentation this evening. We all face these difficult problems at some times, and we need to take a kind of a systemized view and use all these wonderful tools that have been given to us to deal with cataracts and dislocated lenses of these natures. I have no financial disclosures with this regard. So what about subluxated cataracts? What the things that we need to know? What if we know what is the cause of the zonulopathy? Is it a progressive cause? Pseudoexfoliation, as an example, is obviously progressive. Traumatic cataract may not be. Surgically induced may not be. So the extent and the cause are helpful to know what's likely to happen down the road. And most often, these don't exist in a vacuum. Most typically, patients who have a zonulopathy also have other problems. Do they have glaucoma? Do they have iris or pupil deformities? Is the vitreous present in the anterior segment? And what has happened in the back of the eye? Is there retinal detachment, scarring, cystoid macular edema? Just as in most cataract approaches, the whole key is the capsulotomy. If you can form a continuous circular anterior capsulotomy and have an intact posterior capsule, then you can use these wonderful devices that go into the bag and help us. There are a host of capsule tension rings that are available. This is not even an exhaustive supply here. The standard rings, the Henderson modification, and then sutured varieties, the Sioni type, and now the Malyugin type that has the eyelet at the very, very end, so you can put it in through an inserter. And then probably the most useful of all of these tools is the Ahmed segment. We'll try and look at some case types in which we place them. I think the most important consideration is, when do you want to place a CTR? I love the phrase, as late as you can, but as early as you must. The reason I like to place it very late, I like to empty the contents of the capsule bag before we place these things, because very often we don't know the extent of the zonulopathy until we complete cataract removal. And it's usually worse after surgery than it is at the beginning. So it's better to know what you're dealing with. That's number one. Number two, if you place a CTR, it makes it sometimes more difficult to remove the cortex. Number three, sometimes you will damage the capsule in doing the surgery. If you already placed a CTR, you then have this problem where you've got a capsule rupture, and then you don't know whether to remove the CTR, and that can be traumatic to the eye as well. So my sense is it's always better to use capsule support hooks, empty the bag, and then place the CTR of your choice at that time. Here in the United States, MST, Microsurgical Technologies, has probably the most popular capsule support hooks. I prefer these to standard iris hooks because notice the bend here, and notice the broad support. Now they've modified it so you can't feed a capsule tension ring through here, which is a world of hurt. So they've modified. David Chang made it a much smaller opening. But the concept here is that you have something that's smooth on the bottom and long and angulated to mimic the shape of the capsule bag fornix. And you want to keep the capsule bag on stretch while you're doing phaco. If the capsule bag is loose, then the posterior capsule can be floppy, can get caught up in the phaco tip. So having these put tension on the capsule bag, and with this going out into the fornix, gives you broad contact, and that keeps the capsule on stretch, makes it less likely that you're going to encounter it. We'll take a look at some surgical videos here. This is a patient with very obvious pseudoexfoliation. Look, when you start to do the capsulotomy, what do you notice? You notice those horrible folds. It looks like what I call elephant skin in the capsule. As you see that, you take a deep breath and you say, this case is going to be more difficult than expected. I'm going to probably need capsule support hooks. And you'll notice here that I stained the capsule with trypan blue. And the reason for that is that it's much easier to see the capsule edge when you want to place hooks after you may have done hydrodissection or what have you. I also like to use a very sharp cystotome here, a disposable needle, so that it's more easy to tear the capsule. And as you go around, it's much more difficult to generate that capsulotomy because you don't have that peripheral centrifugal centripetal force that is created by the strength of the normal zonule. So it's also difficult sometimes to make the capsulotomy as large as we'd like. Now here I'm placing a dispersive OVD under the anterior capsule. And this was early in the experience with the MST hooks. They only supplied 3. So we're going to work with just 3 here. But notice if you have stained the capsule, it's easier to see the edge. And if you make those little tunnels with the OVD, there's a nice little space to place them. And then you progressively tension them with the slides. So if you have a good enough grip, you can then handle the nucleus. The tension is coming not from the zonule support, but from the capsule support system. You want to use multi-port hydrodissection because it's very often difficult to cleave the nucleus from the cortex in cases with poor zonule. Vladimir Pfeiffer was kind enough years ago to give us vertical chop, and I think that's the best method to use in these situations. So that you chop the nucleus into pieces, the capsule tension is being provided by the hooks. And what you'll notice here, I don't know why this isn't running anymore. It seems to be frozen. You'll notice you're going to start to see here that there's an open area. It's not showing for some reason. At this point, I asked for a capsule tension ring, and there was still cortex in the eye. By the time they brought it to me, I asked for the Henderson modification. So my rule is, and also here, notice I'm going to clean the LECs extensively. And post-operatively in patients with zonulopathy of any cause, there's a great tendency for the capsulotomy to shrink and get fibrosis and phimosis. So extensive cleaning of the LECs. So here, with all the cortex removed, with the capsule tension ring in place, if the IOL is centered and stable, I don't think I need additional support. And in fact, this case was done about 10 years ago, and she still maintains a centered IOL. So that's my rule. Let's look now at the next case. This is a 3-year-old who has Marfan's, and she's got at least 6, if not more, clock hours of zonulisis. And we're going to start the capsulotomy and then place tension hooks to try and bring the bag closer to the center so that we can see the capsulotomy as we're trying to generate it. Very difficult in the youngster. And again here, notice that I've placed trypan blue for 2 reasons. 1, so I can see the capsule edge, but also 2, because in a child, it tends to take away some of that rubbery nature of the capsule, makes it a little bit more like an adult capsule. So I'm going to take the capsule support hooks, and I'm going to just progressively increase the tension to try and bring this lens a little bit more centrally. Now, this would be an example, if you can't get the bag centered, where it would be a good idea to place a capsule tension ring early. The problem, though, is in trying to do the capsulotomy in a child, there's a risk of failure. And so then you're going to wind up with a tension ring and an open capsule. So you have to use both shearing, tearing, and pulling, and Brian Little maneuvering in order to finish the capsulotomy in this eye. But fortunately, using microcapsulorhexis forceps, we're able to do it, maintain the capsulotomy, and then at this point we can empty the contents of the capsule bag and then place the CTR. So now the capsulotomy is complete. IA cleans the bag. And now you always place the tension ring in the direction of the weaker zonular area, so that when you bring it around at the end, you're not pulling on the weakened area. So we feed it toward the open area. And then I'm going to use an ab interno approach through a Hoffman pocket to place a capsule tension segment, an Ahmed segment, that's been preloaded with Gore-Tex. Now, there are a host of ways to tie the Gore-Tex, needleless with needles, but here we're going to use slip knots and then progressively increase the tension to center the capsule bag, and then you can place whatever lens you choose. And this was done when this child was about 3. I've seen her recently. She's 17 and still very nicely centered. Now, I believe if you have a femtosecond laser at your disposal rather, that there are surely times that we want to use it. For some reason, the text isn't coming up, but I use it in cases of reduced endothelial cells, shallow chambers, dense cataract, special capsule issues, but primarily zonulopathy. So if you can, it's very, very helpful. If you look at the OCT of this patient, you can see here where there's absence of zonules both horizontally as well as vertically. So if we take a look at this patient now, we've done the capsulotomy. It's an extraordinarily dense cataract from an injury 20 years earlier. And there are about 5 clock hours of absent zonules. Again, I'm going to place the MST capsule tension or capsule support system. And we're going to take advantage of the fact that the femtosecond laser was able to help subdivide the cataract into 6 pieces. And then when we come out of the eye, we're placing visco agent at the same time. So we try to prevent the vitreous from migrating forward around the area of open capsule. And we're using the capsule support hooks to keep the bag on stretch and keep it better centered. These can be removed either from the main incision or they can be removed from where you place them. Now I'm going to use a Malugan version of a Sioni CTR here. We're going to preload the eyelet with 8O Gore-Tex. We'll remove the needles. And we've gone back about 2.5 millimeters, made a groove and 2 openings, 2 sclerotomies with an MBR blade. And this is the Malugan variety because it has the eyelet at the end. The suture is preloaded. We've cut the needles off. And now we're going to swing that around to the area of the weakest zonules. And we're going to reach through the sclerotomy and bring the ends of the suture out through the 2 separate sclerotomies. The groove is made so that we can bury the knot in the groove. That's optional. This patient had significant corneal astigmatism. So with a Sioni type ring or a standard CTR and an on-med segment, you can indeed use a toric or multifocal or what type of lens you choose. And again, the tension on the knot is progressive so that once you are satisfied that you have the right position of the toric lens, then you can finish the knot. And here I'm placing fibrin adhesive to close down the conjunctiva. And here's what the patient looked like on the first postoperative day, a perfectly centered lens. Now this is someone who has about at least 7 or so, maybe 8 hours of zonulysis, but also has a cyclodialysis that's keeping her pressure normal. And during cataract surgery, in the presence of a cyclodialysis, there's a risk that you can get a massive suprachoroidal effusion if you get misdirection of the balanced salt down through the cyclodialysis. So I prefer, here we can take a look on anterior segment UBM. You can see the cyclodialysis right here. So I prefer to close that cyclodialysis intraoperatively. Now in this patient situation, we wanted to maintain the cyclodialysis postoperatively. So we closed it temporarily with a suture. And then we took that suture out at the end of surgery. Here I'm placing some stain, triamcinolone, to look at the prolapsed vitreous. And notice I'm taking a limbal approach to remove the prolapsed vitreous. I actually strongly prefer a pars plana approach, and you'll see why later on. So I'm taking a double-armed 10-0 polyester suture, and I'm going across the chamber, underneath the iris, through the ciliary body to temporarily close the cyclodialysis cleft during the surgery. And we'll tie this knot over the conjunctiva, and then we'll just remove it at the end. And the purpose of this is to prevent BSS or fluid misdirection. Notice, again, the lens will tend to move a lot. It would have been nice to be able to use a femtosecond laser. This patient, however, required general anesthesia, and so it was not available to us. All attempts to make the capsulotomy large are sometimes very difficult with zonulopathy. You think you're making it large enough, and then by the time you get the bag empty, it's small, and sometimes you have to enlarge it. Here, it was not difficult to remove the cataract. It was a soft cortical cataract. And so we're just basically going to phacoaspirate it, and we're going to then always place OVD when we come out of the eye, and often place dispersive OVD on top of the area of open zonule. So to the best of my ability, I'm not noticing any prolapse vitreous. We removed that before. I'm going to add OVD as I come out with the phaco instrument. And then I think it's a little bit easier to remove the cortex by manually. So I'm going to place a standard CTR. Now, there are two types of CTRs. The ones that are made by Morcher, which you're seeing here, tend to be more rigid, and the ones that are made by Oftec are less rigid. Now, the capsulotomy was smaller than I thought and smaller than I wanted, so I'm going to enlarge it after I've placed the CTR and removed everything from the capsule bag. So, and again, you don't want a capsulotomy that's too small, but you want to make sure that it's a continuous circular tear. And now I'm placing an Ahmed segment. And this is with 10-0 polyester. And after that's in place, in the area of greatest zonule weakness, I'm going to clean these LECs extensively. And again, that's to prevent postoperative capsule contraction from fibrosis, zonulisis. We're trying to prevent that. And again, you can place, once you have your bag firmly positioned, you can place any IOL you choose. Now I'm removing the OVD with the vitrector just to be certain. And son of a gun, I see I've got vitreous presenting at the wound. So now I'm going to go through the pars plana and deal with the vitreous. Today, I strongly prefer a trocar system and to remove vitreous from the pars plana. I think this case is a very, very good lesson as to why. Didn't have trocars at that time. Again, her picture's not showing up for some reason, I guess due to the transmission, but in any case, perfectly centered lens 5 years out, and using pilocarpine once a day has kept her cyclodialysis cleft open, so that managed her glaucoma. There's another type of hook that I like very well. These are called Yaguchi Kazawa hooks. They're made in Japan. They're more difficult to get a hold of. You have to go on their website and you deal directly with the company. But what's also nice about these hooks is that they go out into the fornix and keep the capsule bag on stretch. They kind of look like a hammerhead shark. These are specifically dulled and gentle on the capsule. So unlike iris hooks, which may be sharp on their tip and can tear a capsule, these won't. And they come 5 per package. So you've got 5, and each of them have a 2-point fixation. You've got a nice 10-point fixation. This is an interesting case. This is obviously a congenital form of zonulisis, and it runs about 4 clock hours in both eyes. As you can imagine, there's significant lens-induced astigmatism. This is a woman in her upper 30s. Her biggest problem is nighttime driving. She has a modest degree of cataract here in her left eye, very small amount in the right eye. Now, let me just freeze it. One of the rules that we go by is that if you see a lens that's flattened like this, it generally means the opposing zonular fibers are very strong. If the lens is very, very rounded but loose, it typically means you may have a more diffuse zonulopathy. So knowing that the opposing zonule is strong would kind of guide us as to how we want to approach this. So I'm marking so that I can have an appropriately sized and placed capsulotomy. Again, I'm going to place trypan blue. We're going to use a sharp cystotome here, a needle, and we're going to tear away from the open zonular area, or I'm sorry, toward it, my mistake, away from the strong zonule. And then we're going to complete a circular tear capsulotomy. You want to make sure that we leave enough of a residual capsule peripherally that it will hold a CTR or a segment or what have you. So I'm going to empty the capsule bag. Again, it's a 38-year-old, so a soft cataract. And here I'm going to place one of those Yaguchi-Kozawa hooks, and notice it's got the 2 points fixation. I'm going to place it to try and bring the bag on a stretch. Really difficult to move this bag because the opposing zonular fibers are very strong. Once we remove the soft lens material, things start to look a little bit different. I'm going to place this is a rigid mortar type CTR. And once this is placed, and once we remove the Yaguchi-Kozawa hook, what we notice is that this bag seems to be very well centered. And notice the hooks will also cause a little retention of cortex. So we remove this now, and we'll take out the cortex in a bimanual fashion, clean the LECs, and what we notice again is that we don't have an appropriately centered or sized capsular opening. So I'm going to make another secondary opening in the anterior capsule, so we'll make it a little bit larger. And again, I'm going to clean those LECs, posterior capsule, etc. And again, I'm noticing that the lens itself is very well centered, but the capsulotomy isn't. So we're going to make, here actually, first I am doing, you can't see it, intraoperative aberrometry, because in addition to lenticular astigmatism, she also had corneal astigmatism. So we're setting the axis for a toric IOL. And I'm going to enlarge her anterior capsulotomy so that we can have an appropriately sized capsulotomy and also reduce the likelihood for capsule contraction postoperatively. And so now the IOL is perfectly centered. It's on axis, and I thought I had done my job. My rule is the lens is centered and stable, I don't do anything else. But now a year later, after her posterior capsule's been opened, look, those very strong zonular fibers on the opposing side cause the lens to move in that direction. So now I've got a malpositioned lens capsule bag CTR complex. And I'm making Hoffman pockets. I've gone away from that, but at that time I was making Hoffman pockets. And we're going to now suture the capsule tension ring to the eye wall to create centration. So here is an MVR blade going through the Hoffman pocket underneath the CTR in the capsule bag. Now, if I hadn't opened already the posterior capsule, I would have placed an Ahmed segment. But since it was open, I decided instead to sew the CTR with a lasso suture coming from the from an opposing paracentesis. And then we pull this over and we can see we can center the lens. And so we bring both ends of the suture out of the Hoffman pocket. And notice one is more posterior than the other. The one that goes posteriorly is further away from the limbus, so you don't torque. And then here we progressively tension it till we get centration. And then we complete our knot. And now we've got a centered IOL. How are we doing on time? Am I taking too much time? Because I can move on. I can't hear you. You're muted.
Yes, it's perfect. You can have.
I can't hear.
You can't
Yeah,
hear me?
I don't hear you.
You can't? I'm unmuted.
Ah, I hear you. I'm sorry.
Okay. You can have still like 10 minutes.
Okay, I'll move on.
6 to 10 minutes.
All right. So this is an industrial accident, a man working on a farm who was damaged. His left eye was damaged by the belt buckle of a saddle, of a horse saddle. You notice he's got a fixed dilated pupil. He also has a dense cataract. But the ever interesting thing, when you look at his topography, you can see that in his cornea, he only has a little over a diopter of astigmatism. But from a refractive standpoint, he's got about 3.5 diopters. So we suspect lens tilt. I have a strong preference not to do an iris cerclage and a complex cataract at the same setting. I know a lot of surgeons do that, but because we have to preserve the capsule bag with such importance after we place tension rings and what have you, and segments, Cioni rings, artificial iris, all of these devices go in the capsule bag. And if we injure the capsulotomy after we've placed them, we have to take everything out. So I gave this individual the choice of having an artificial iris or coming back for a second surgery, which we do a cerclage. He chose the artificial iris. Notice here, this is the OCT from the femtosecond laser. Notice we can see he's got some zonulisis, probably about 3 clock hours here inferiorly, and about another 2.5 or 3 clock hours here superiorly. So he wound up with significant lens tilt. And here we've done the laser part of the surgery. And notice he also has a pterygium on the temporal side. So I'm removing it as well. Temporal pterygia often have a greater likelihood of neoplasm. And so we're going to remove this and send it for pathology. And it did, in fact, turn out to be a CIN, which was treated postoperatively by his referring physician some 1,500 miles away. Now, I'm marking here so that I'm exactly 180 degrees apart because I know that I'm going to put Ahmed segments. Now, notice how that lens moves when I try and loosen the capsulotomy. And that's because of diffuse traumatic zonulisis. We'll speed this along. You've seen a lot of that already. It's delayed a little bit. So we've emptied the capsule bag of its contents. I'm placing a CTR. I wish it would run now. Here we go. Let's see if it'll run now. It doesn't like to be stopped, I guess. I'm sorry.
I think it will work, but it needs some time.
Yeah. What I'm trying to demonstrate here is the capsule bag has been emptied of its contents. We're placing a CTR. I'm going to place an artificial iris. And after that, I'm going to place 2 Ahmed segments 180 degrees apart. And then we've placed an amniotic membrane over that area. So the video doesn't want to run, so that'll save us some time. And this is what he looked like post-operatively. The artificial iris from Human Optics can give us this just absolutely perfect match for color if we spend the time to take the right photos. The upper lid is hiding the Ahmed segment there, but how perfectly centered we can make these things.
Is the iris segment in the back or sutured to the?
It's in the bag. It's in the bag. So the iris, I'm sorry I couldn't show that in the video. Unfortunately, I stopped the video. So the iris first goes, the lens goes, the CTR, then the lens, then the iris, and then the Ahmed segments go in the capsule bag, the last thing. And I'm sorry I couldn't show you the video. I just want to talk very briefly about late malposition. For some reason, my pictures are not showing up. But late decentration is mostly due to zonulisis, which probably has a lot to do with phimosis, fibrosis, and fibrometaplasia, which is why I like to clean LECs. But pseudoexfoliation and other conditions that are associated with breakdown of the blood aqueous barrier seem to be the most common cause for progressive zonulisis. This is a whole new pandemic we're dealing with. Pars plana vitrectomy is another cause, whether it's due to an alteration of the blood aqueous barrier and progressive zonulisis, or whether it is due to the vitreoretinal surgeon lysing the posterior zonule. It's not clear. But what concern I have, since I am not a trained vitreoretinal surgeon, I don't go into the back to remove loose lenses. I've had the malfortune of dropping a lens in a post-vitrectomy eye, and when they go very quickly. So I developed this technique of putting a suture underneath the IOL before I do anything with it. And that, we call it a basket safety suture. So it's a STC-6 needle that we bend at its tip, and we go behind the IOL. And then from the opposing limbus, we take a bent 27 gauge hypodermic needle, about 2.5 millimeters back. And then we dock the bent STC-6 needle, and we make this little safety net underneath. Now, in a post-vitrectomy eye like the one you're seeing here, I do 2 horizontal mattress sutures, one coming from the vertical meridian, the other horizontal meridian. And once I've done that, I can then choose to either take the lens out or suture fixate the lens to the iris, to the sclera, whatever is most appropriate. When dealing with the malposition lens, I always try and salvage it if the lens was satisfactory to the patient in the first place. In other words, was it the right optic? Was the lens causing any problem? Now here's how you make that bend. About 3 millimeters from the end, you bend it 15 degrees. And the reason that you bend it is so that when you pass it into the 27 gauge needle, you have friction, so they won't slip apart. So you want to be able to pull that needle out and bring the suture along with you. And then once you've done that, you can do anything you want to do. Here's just an example. I didn't plan to do it in eyes that still had vitreous, but when they have like 6 clock hours as this patient, I thought it'd be a good idea. So what we're going to see here, this is a patient who has RP, progressive zonulopathy, a 7 millimeter PMMA lens, so I don't want to remove it. So I'm going to place 1 mattress suture underneath the lens across the pars plana, about 3 millimeters apart, 2.5 millimeters back from the limbus. And you do this in a horizontal mattress fashion. And you tie it not too tightly. You don't want the lens to be pushed up against the iris. You just want something that it can sit on. So it's a little safety net. Now, this is what I call bread and butter. This is how I prefer to do them. I'm going to make a radial mattress, a radial oriented lasso suture. You can do this needleless or with the needle on. This is Gore-Tex suture. We're going to dock it into a 27 gauge needle that comes from an opposing limbus. We start 3.5 millimeters back, and we turn the suture around through the opposing paracentesis and dock it into the 27 gauge needle at about 1.5 millimeters anteriorly.
And
So
the loop, yeah, one pass was in front of the loop and
one is in front and back. And what notice you'll see when I pull the sutures that the lens moves. If the lens doesn't move, then you don't have a loop. So the first loop goes through the bag underneath, and then the second pass goes on top. And you'll watch now as we pull this across, you'll see that lens move. So we've got a lasso around the loop. We're going to pull this loop, and then boom, the lens moves. So now we know. And then we do a 1, 1, and 1 slip knot, and we progressively tension these until we like our centration. So this bite's about 1.5 millimeters apart, and now we're tensioning it, and then we complete. A Gore-Tex will not open. So all you need is a 1, 1, and 1 slip knot, and then the knot is small enough that you can bury it inside the needle tract. So here we cut them short, and that's the nice thing about Gore-Tex. It's very well tolerated, and the knots won't open, but you must bury the knot. So here I'm going to take a micro forceps and bury the knot in the suture path. I don't think it's necessary to bury the suture itself. And I'm going to place some hydrogel bandage over this, some Rassure, because I don't like hypotony. So I'm going to make sure these don't leak, and then I'll close the conjunctiva. And so that's what I call, that's standard nuts and bolts 3-piece IOL. You can do that with the CTR, you can do that with, or with the haptics of a single piece IOL. I think I've taken more than my time, so I'm going to stop here.
Perfect. This was a great collection, great insights of detailed techniques. Thank you very much. I think I learned, I think everybody attending, we have more than 1,300 attendees. So I think it was extremely useful. One of the comments, just to stress that about in congenital subluxation like Marfan syndrome, you stress that we have to suture the back because it's a progressive disease. We cannot just implant the lens inside the bag and just leave it. Correct?
I agree. Yes, absolutely. That's why it's nice to know what is the underlying condition. And if it's a progressive disease like pseudoexfoliation or any of the progressive zonulopathies, RP, ROP, etc., any of the metabolic disorders, then you know it's going to be worse later on. So yeah, in that situation, I would suture. But if it's an elderly patient with pseudoexfoliation, or if it's a surgically induced zonulitis, trauma, then it may not be necessary. In other words, you may be able to, what you have on the table is what you'll have down the road. But any progressive disease, you need to treat it further down the road.
Okay. Thank you very much. Really, we enjoyed it. And we move on to Professor Vladimir Pfeiffer and for another round of interesting cases. Vladimir, you can share your screen.
Trying to share.
Yes.
I'm fine.
Yes,
Okay.
perfect.
Okay. Now,
Just make it full screen.
yes.
From the slideshow down. Okay.
Okay, we are fine. At first, I would like to thank for the invitation. I'm very happy to be together with you. And my talk is about mal-positioned lenses and the techniques that we are using to solve these problems. So no financial interest in the matter presented. So we know if we have no zonular support, then we use different techniques. And I'm going to speak mostly about Yamane technique. Chariot started with interscleral fixation. Argaval changed it a little bit by gluing it, which is very important because we do not have the hypotony. And then Yamane came with his fantastic idea with sutures. This is Yamane's video with sutureless incision through the conjunctiva and using a 30 gauge needle and docking the haptics into these special 30 gauge needles. And the second haptic he did from the stab incision, put into the syringe, into the needle, and then it was just pulled out, and haptics came out of the sclera. The flanges were done. So we have to know that it is sutureless through three-point incision and less traumatic surgery that we can do today for solving these problems where we have no zonal support. So let's go to my cases. This is one of our cases where the IOL and capsule bag fall down. So what we did, we took it out and implanted a second lens. And now I would like to show you that also in very small pupil cases, we can very safely perform this technique. So this is a needle. The haptic is docked into the needle. Then this needle is released. We just release it. And at that time, I did hold these needles with the fingers. On this needle, on that side, I already have a syringe on it because it's easier to hold it and to do the surgery with it. Then through the same incision, to the main incision, I'm docking the second haptic into the needle, and then both needles are pushed out in the same way as the tunnels were done. So this is very important that we do in the same direction. And all the time we have to have infusion. This is a pars plana infusion, this infusion anterior segment. And then the flanges are done on one side and on another side. And with this technique, I'm doing it from 2017. So I have 4 years experiences, and I didn't have any luxation of these haptics out of the sclera. So they're very strong sitting there. And I think it is very good, or the best technique today for these cases. So the lens, the needle I'm using is a Stereomedics needle. It's a thin walled needle. Then I need a end gripping forceps and the lens. This is Abbott or now Johnson & Johnson IOL. And I think even the better lens and more forgiving lens is the Zeiss IOL, the Lucia 3-piece. So this is how this lens is being put into the shooter cartridge, injected into the eye. If possible, it is better to put the haptic onto the iris, and always it's very important to mark where the haptics are going to come out, where the incision is going to be, and we mark. And then I hold the eye with the forceps when doing a tunnel. Tunnel is about 1.5 to 2 millimeters long. And here, these marks are 2 millimeters apart and 2 millimeters down. So most of these videos are unedited from the time when I grasp the haptic and when I do the docking. So you will see that it can be done pretty straightforward. So now the second needle is going in. Note that this needle is bent about 90 degrees and the other needle is bent 45 degrees. So we redirect the needle in the other direction, and now it should come out here. So we don't have a very good feeling until we don't see the needle. Now with end gripping forceps, the haptic is grasped about 2.5 millimeters, 3 millimeters from the top, so that we can go through 3 millimeter incision that I'm using for these lenses. And now this haptic is docked into the needle, as you saw it before. About 2 millimeters is enough, because this haptic stays very hard in the needle. Then, in the direction of the tunnel, it's very important. The needles are pulled out, and at first we see a blue haptic here. Then we release this needle, go to the other needle, take a forceps, and do the flange. We don't touch the haptic. We can have this kind of the cautery, or a little less cautery. I think both do very well. So also the flange is done on the other side, and then the haptics are pushed backwards into the sclera. We put it through the conjunctiva. We don't suture it. I try to push it a little bit into the sclera, but I want to see them all the time. I don't want to put them totally in the sclera, so I don't know where they are, if I would need another surgery, or this patient would need another surgery. So in this case, we did take other lens out, so we have to do some vitrectomy to take other pieces out. Otherwise, this patient was a positive vitrectomy patient, and this is the case at the end. We remove the infusion, and
how important is the acute chamber maintenance, Vladimir?
Very important. I think we shouldn't do this surgery without the infusion. So I will talk about this. This is ectopic lens in the child, and this is the surgery. So always we have to have an infusion when doing the surgery. This is the second needle that is bent 90 degrees. We always mark the position where the needles are going to go in, and we take 2 millimeters from the limbus and 2 millimeters apart. And what I'm doing, I do the parallel tunnel parallel to the limbus, not 20 degrees down as the Amani does. It's very important to check if the lens, if the haptic goes into the needle. It's very important, because if you found that it doesn't go in the eye, then you have a lot of worries. Then the eye is hold, the needle goes in, tunnel about 2 millimeters, 1.5, and it's redirected through the stab incision, second stab incision. The haptic is grasped and docked into the, this is straight forward. Sometimes is a problem, but mostly it can be done easily. But one should train this out of the eye just with the haptics and with the needle. Now, I'm holding this needle because this needle was on a syringe. I took the syringe away, and now I will release the needle. So it's much more precise if you have a syringe on the needle. Now there is a second haptic. We already have the needle inside the eye. I'm grasping it, and now look how I'm changing the direction, the bevel of the needle, so that it is in fantastic position to be docked in. It had to be very nicely aligned. So again, about 2 millimeters, and now both are pulled out of the eye and flanges are down on one side and on the other side. The infusion always has to be on. My settings are 50 millimeters of mercury, and when I'm doing the tunnels, then I go up to 30 millimeters of mercury. So we don't have to touch the haptics, we just do the flange without touching it, and it should be dry. And at the end, you can see how nicely this IOL is centered. So And this is the eye at the end of the surgery after myotics were administered. We don't need to suture this. This is a 6-year-old child. Visual acuity 1-0 without correction. And we see the haptics here. So this is his eye about 2-3 weeks after the surgery. So another case, subluxation, ectopic lens. Here we have a little bit better microscope. We just wanted to show how thick the lenses are. I've done a small opening here in the anterior capsule. Then I am doing a dry irrigation aspiration, installing the visco and aspirating with the irrigation aspiration. Then the capsular bag is taken out because I think it has no sense with these low zonules to implant the rings and whatever. And after 10 years, we will have a subluxation again. Then at least we have to suture on 2 places. Then the needle goes in. I've lost the infusion, you can see, but because there are so small incisions, the eye is stable. In this case, I've secured the needle, and now I'm holding the eye and doing a second tunnel. This needle is 90 degrees bent, the other is 45. Now, at that moment, we have 30 millimeters of mercury of pressure in the infusion. Now, we redirect the needle. The bevel is towards the haptic, and the haptic, I'm trying to push the haptic in. Now the viscoelastic came out. I still don't hold very good the haptic. Now I've regressed, and now I'll be able to push it into the needle. What is important in this surgery is that we don't bend the haptics. We have to take very much care about the optic-haptic junction and not to damage the haptics, because then we are going to have a tilt. And we have to measure 2 millimeters and go limbus parallel, not to have a tilt. If we will go down, maybe we will do the tunnel about 1.5 millimeter, 2 millimeters, and then we won't know if we are here or here. So I think that going down 20 degrees is a mistake. So another case, stops always. This is the lens was taken out, subluxated lens. And now we are going to do the same technique. So always mark the center and the axis where the haptics are going to go in. I'm sitting at 12 o'clock. This is a 3 millimeter incision, and the IOL, this is post-vitrectomy eye, and the IOL is implanted into the eye, and I don't have a lot of iris here. So this is, I'm not able to put it on the iris, and you see how it's dangerous to fall in. But we have a second haptic, and this haptic is holding it outside. Then the normal tunnel is done. Again, limbus parallel. And now with this haptic that stays out, we can manage to put the lens in the position that's favorable for us. And then we just adjust how long we hold the haptic, regress, and push in. And now again, I'm stabilizing the needle, taking out the syringe, and then releasing the needle. I think it's very important. These steps are very important. Holding the eye and doing the tunnel, limbus parallel with 90 degrees needle, because then we can repeatedly do the limbus parallel incision. Now we grasp it and turn the needle bevel to the haptic and put it in. This one went very smooth. And we have to have a VSS in the syringe, otherwise we're getting the air into the eye. And now both are taken out. And we will flange them as before. So the care is taken not to bend the haptics. We'll do the flange here, flange on the other side, and then we'll try to center it. But we are not happy with centration. So we are going to shorten this haptic again. So we can again take out the haptic, shorten it so that the lens stays, that at the end the lens is really central. And now you can see that it's, I would say, perfectly centered. Okay. And that's the end. Okay, this is another case. Here I just want to show you, because the pupil is very bright, that the lens can really be implanted very centrally and very good centrated. And if we look at this patient, we see the haptics here. Until now they didn't protrude. I hope they won't. And this is another case. We have a fallen IOL and the lens, IOL and the capsule. And now we are indenting the sclera to bring up the lens so that we can grasp it with the forceps. This is a 23 gauge forceps. And now for sure, we are not going to reposition this. And I'm repositioning less and less lenses since I am working with this technique. We just cut the lens. Important is to have a 23 gauge forceps, and that you can grasp when the forceps is far inside. And then usually, I think with with the hydrophobic lenses, I do cut them 3 times because they are harder. Then the IOL is implanted into the, and the normal Yamana technique is done. We have seen that for already a few hundred times. So I will just show you the end of the surgery. This is nearly perfectly centered. It's a little bit dislocated, but here is less iris than here. But it's stable, that's important. So we can also have problems. You see, this haptic is already done. So I'm doing the second haptic. Okay, goes nice, beautiful. I'm pulling it out, and what's here? I don't have a haptic, so I've lost the haptic. I've really got a little bit nervous here now. And I thought what to do. Then this haptic, this needle was helping me. I have to go out, and I have to, my idea is to bring the haptic on the iris again and do the docking again. So I'm trying to take it out, but I wouldn't be able, so I need another instrument. And my very favorable instrument is Ogawa lens dialer, which I'm using a lot of times for a lot of things. And here I just go, grasp the haptic, pull it, and bring it into the anterior chamber in front of the iris. And now I'm hoping I'm able to do the docking again. So there is a needle, there is a haptic inside, and I would be much smarter if this, I would put it back in, because now the angle is not exactly good. And I put it a little bit more in, as you can see here, and now the angle is so that I can put or dock the haptic into the needle. So this technique has really changed my life. Now here you have to take care, because now the infusion was occluded and I was getting hypotony. Now infusion is open again. And then normally the flanges are done and I calmed down. So we see a nice centered lens. This is a new thing that is on the market already. It is a needle holder. You can just grasp the haptic. This one is 27. I don't know how 30 gauge one is working. Okay, then I will show you a case of a traumatic eye where it's gonna run or not. This is postoperative situation after trauma. Okay, and it's total aniridia. And here, here we are trying, we will implant the artificial iris and the IOL using the Yamane technique. So this artificial iris trimmed down to 10.5 millimeters. And the Yamane technique is used to dock or to bring the haptic through the artificial iris. So we are putting this IOL in the center, about 2.75 millimeters from the edge of the artificial iris. Now doing the tunnel the same as we saw before with the Yamane technique, docking the needle on one side, then on another side. In this artificial iris, it is important that artificial iris never touches any intraocular structure. Now we have docked the other, and we are just pulling both needles outside, and we will see how nicely this complex of IOL and the artificial iris is going to center. Once again, artificial iris should never be in contact with the ciliary body, with the rest of the iris, because then we will have a inflammation that will come out maybe years, 2-3 years after implantation, and then we will have a lot of problem. And I think there are going to be a lot of problems with this irises. This is the case at the end of the surgery. These are some pictures of the patient. Months after the surgery, he's doing well. He's now about 3 years out, 2 years out. This is his face. Then I will show some other cases, not important cases, but interesting cases. So the patient presented to me with a subluxated IOL. I didn't know what happened. And then I saw, oh, the haptic is missing. So in this case, it's a straightforward thing to do. I always like to grab from this side with a 23 gauge instrument and then cut the IOL. If my incision is, I didn't want to enlarge incision, it's 2.2 millimeter incision, and I just want to cut it. And usually I cut it into 3 pieces. You can cut it into 4 pieces. This is much better than cut it just in 2 pieces and try to pull 3 millimeter big IOL through 2.2 millimeter incision, or you can enlarge an incision and then do the just two pieces. So it's normal. One is scissors, and now there's the forceps. I wasn't sure, I didn't cut there, so it was a little bit traumatic. And then just the other IOL, another IOL is being implanted into the capsular bag. So don't be afraid to take a lens out because it's a straightforward procedure. It's not difficult. So this is another technique I'm using lately for repositioning the subluxated lenses when I don't want to take them out. So what we have is a 6-0 Porin suture. Now we brought one out. We got in 3.5 millimeter behind the limbus. Now it's 2 millimeter behind the limbus, and now we are bringing this suture out. So we did the loop. Yes, Sam showed us very nice with the his Gore-Tex suture. We did the flange. So one flange is here. We have a loop here around. So we can stretch as much as we want. Then we cut away this suture and we do another flange. So there are two flanges and there is a loop around the haptic. So one, it went from behind in front, and then we are not suturing anything. We are just pushing the flange under the iris, under the conjunctiva, and we did 2 sutures, and that's the case at the end of the surgery. Another case is a subluxated IOL, subluxated lens. It's an ocular trauma. In this case, we are going to do the surgery similar as Sam showed us. So we did a capsular axis. We have just one iris hook. It's just normal iris hook. And then we did a phaco, which I don't think is important to show. Do I have still some time to go to the end? Okay, I didn't hear, but anyway. Okay, now
Yes.
I will jump over this phaco. It's not so important. So phaco was done normally. Irrigation aspiration is done. We are trying to clean up as much as we can, and polishing is done of the posterior capsule. And now the capsular retainer ring is going to be installed, but we are going to secure it with a 6-0 Prolin suture. So this suture goes into the needle, and we bring it with the needle into the anterior chamber. Now here you can see that I'm pushing the suture into the eye and taking it out through the main incision. So now the flange is done. Because the suture is already gone through the eyelet of the capsular retainer ring. So suture is through the capsular retainer ring, through the eyelet, and flange is there. So all these our surgeries became much easier and less traumatic with these new devices like Yamane technique, like this 5 or 6-0 Prolin sutures. So what you see here now, I'm pulling a suture out. Here is the flange, holding the eyelet of the capsular retainer ring, and I will pull it here, cut it, and do the flange. And I can adjust it, make it short and shorter. Suture can be done. I was too near to the eyelid, so patients did feel something. Otherwise, they don't feel that. And now I just put the conjunctiva or under the conjunctiva, and this is a nicely centered IOL with the capsular retainer ring and the 6-0 Prolin suture. And I think they won't degrade like 10-0 sutures did. I have another case. 6-0 Prolin suture. This is again 6-0 Prolin suture. And what we are doing here, we will take 4 sutures out of the eye, and we will implant the plate haptic IOL into the eye without capsular support. So 4 sutures are taken out in the same way as you see here. The flanges are done on these sides, not to lose the suture. They will be done later on. And then I just go through the through the haptic of the IOL with the needle, then bring the suture through it and cut it away and do the flange. So this is a flange, and we do 4 such flanges. Maybe it can be used for multifocal lenses if we don't have a capsular support, whatever case. Then this lens is implanted in the eye. Here are 4 sutures looking out, and then we just flange them. And here we can also play with the effective lens position. Then we can bring the lens forward if a patient is in a plus, we can just bring the lens forward later on, just to shorten these flanges. And this is how it looks like after the surgery. No sutures, just the incision, main incision. So in conclusion, the Yamane technique really changed the way I do the surgery today, and I have much less stress than with the cases before when we were suturing. And for all on the world, I would like to keep this lens with the capsular back or with the capsule inside the eye and try to reposition it. Now I just take it out and do the Yamane, because I think there is much less material left in the eye. There is much less inflammation in the eye. It's a really brilliant technique of Yamane. I've a little bit changed the technique, but mostly it's done like Yamane does it. So thank you very much for your patience.
Excellent, excellent, really perfect collection. Sam, can you give us your reflections about the Yamane technique? This is number one.
Yes, for sure. Are you seeing me and hearing me okay, I hope?
Yes, yes, yeah. Perfect.
You know, we also have had a lot of experience with Yamane. Also, not cases that we've done all the time, but others that have been referred in. And we are seeing problems. We've seen tilt, we've seen optic capture, we've seen CME, we've seen extrusion of the flange. So while it definitely is faster, easier, with not a very significant learning curve, we do appreciate it, and we do think there's definite place for it. But Vladimir showed some really remarkably innovative things that can be done with flange, not just to fixate the loops of the IOL. The problem that I have, though, in using it for malposition lenses and CTRs is that it's much more difficult to titrate the tension of the flange than it is of a slip knot. So we've actually gone back to the Gore-Tex. So, I mean, there are places for everything. I think we need to have all of these tools at our avail. Without hesitation, though, the hardest part for the surgeon to learn, and Vladimir spends a lot of time on this, is the needle passage in the sclera. They have to be symmetrical, and they have to be at least 2 millimeters into solid tissue. And if they are as symmetrical as possible, then tilt and decentration are not going to be a big problem. But we've had I had a case referred just recently where the lens was so tilted that it was eroding through the iris. We had to take it out, use an artificial iris, and what have you. And the patient had chronic CME. So we love the technique, don't misunderstand me, but it has to be well done. And I think the symmetrical passage of the 30 gauge needle into the sclera is really the secret of the surgery. Now, Goiter, G-E-U-D-E-R, a German company, working along with Yamane, made a device that you place on the limbus and has passageways for the needles that makes it a little bit more exacting. So I would encourage people who are learning Yamane technique to take advantage of that tool, because it will make it easier for them to make symmetrical passages on both eyes, on both sides of the eye. And I think that's really key. For those of us who have intraoperative OCT, then you can see whether you have tilt at the time of surgery, and then readjust, repass if you need to. But again, as I said, it's wonderful in the hands of someone like Vladimir, who does it so beautifully and really understands the nuances of the intrascleral passageways. But for people who just want to do this very quickly and in a sloppy fashion, it's not a good technique. Like anything else, you have to do it right.
Okay, Vladimir, do you want to comment?
Yes, I would like to say something. What was said is totally right. It's very important. Therefore, I've changed some things. The incision, that the tunnel that Yamane says should go 20 degrees down. So if you think, it is long 1 millimeter, it's going to be so deep. If it's long 2 millimeters, it's going to be much deeper. And so not the same, to do the same thing on the both sides, then you have a tilt. So what I'm saying is we have to go limbus parallel. And then it's not important if the tunnel is 1.5 or 2 millimeters or 1 millimeter. It's on the same height. So this is first very important thing. Go limbus parallel. About the device, marker device from Goider, we have to know that one eye is white 11 millimeters, second eye is 12, one is 12.5. So where our needle is going to end at the end, I think it's wrong to use one device for all the eyes. Then they would say, okay, this is a 11.5 millimeters white to white, then this is the right for this eye. And then the bigger eye, the other one. And I think also that, and to be honest, to put something on the eye, we've tried to mark the axis of the, when putting in the toric lenses, to put, to mark the axis. When you put this thing on, you never know where you are. You're a little bit on this side, you're not in the center, and then also the markers are not correct. And also this happens here. So I think the way I'm doing it is working very good in my hand. We did have a tilt, but when we did make better and better technique, the tilt is less. And second important thing is, first needle has to be bent 45 degrees.
First needle means the distal haptic or the proximal?
The needle that, the
distal.
dirty gauge needle that you're using, the one that goes away from you, has to be bent 45 degrees. But the other ones that goes towards you has to be bent 90 degrees, because then you are able to make repeatedly the same tunnel. If you have a 45, it's very difficult to do just the same tunnel. So I do bend 85 degrees, the second needle that goes towards me. And these are the key points for this surgery, I think.
Perfect. And about the sutures, Sam, you're using, and most of the people in the US, many in Europe are using essentially Gore-Tex, but the 8-0 Gore-Tex, we don't have it in our place, so we use 10-0 or 9-0 Prolene. Is that okay for fixation or not? And I saw Vladimir is using 6-0 in the flanged fixation. 6-0 Prolene, correct?
Correct, yes.
So what do you think about Prolene and the size of the sutures?
I would not use 10-0 Prolene to fixate to the sclera. It will biodegrade over time, particularly if it goes through an eyelet. The friction on the eyelet in time will cause it to degrade. 9-0 will last longer, and it's unlikely to degrade enough to be a problem. Some people are using even 8-0 Prolene. We were using 10-0 polyester when it was available because I like the size. It's unfortunate Gore-Tex isn't available because it has so many wonderful properties. They're easy to tie, easy to see. Tissue grows into it, becomes incorporated, extraordinarily biocompatible. You still have to bury the knots. It's wonderful, wonderful material. So I'm sorry it's not available. There's a challenge with it because it says on there, not for use in the eye. And some hospitals and surgery centers won't let surgeons use it. But I only use 10-0 Prolene for suturing iris to iris. I don't use it for suturing IOLs, CTRs, or anything of that nature to the sclera because of progressive biodegradation. 9-0 is acceptable, 8-0 is probably better.
And Vladimir,
go ahead, I'm sorry, I'm finished.
No, Vladimir is using 6-0 Prolene.
Yes, look, we were using 10-0 Prolene, and what happened, everyone knows what happened. So we were starting using 9-0 Prolene, and on last meeting in Paris, I think Boris showed us that 9-0 Prolene degraded. So I wasn't feeling very good. Good. Okay. And but I think with this thing that is now with a or 5.0 ProLens, we can be very happy, and it looks to work. Until now, I'm happy with it.
Okay, perfect. So if you allow me, I can start.
Please.
And please.
Looking forward.
So I have no financial interest. I'm going to pass over the things that already were touched on before, but to stress that subluxation is a real challenge with different scenarios, as we have seen so many different scenarios, so many different etiologies that we have to be prepared for, and each maybe you change the plan, but the concept has to be clear. So either you diagnose it preoperatively and you know that you're going to do a subluxated lenses, or sometimes you diagnose it intraoperatively if you did not diagnose it earlier, or it can happen as a complication intraoperatively as well. And we have seen how these nice tools are needed and how they are used. So I'm not going to talk about this, and just going into the cases that again is stressing this fold sign, but Dr. Muscat said it's elephant skin sign. It's very important. If you did not notice that this case is subluxated, then once you see the fold signs, then you are sure this is subluxated, and you have to change the plan, the size of the rexes, the settings of the phaco later on. So it's important to realize that there is subluxation. Here's an example of a traumatic case, and as you can see here, again, the fold sign of the capsule is very clear. So again, immediately you have to calculate how big you want the capsular rexes to be, because you might need a capsular support later on. And we know that traumatic cataracts are not progressive zonulisis, so you can depend on capsular support if it is reasonable at the end of the surgery. All the surgery will be done in slow motion, the infusion, so as the pressure inside the eye is low, everything is careful. If you are going out with the phaco after finish the phacoemulsification, you have to inject viscoelastic so as not to go rapidly decompressing the anterior chamber, so the zonules will, maybe with the anterior vitreous face, will go forward. Having bimanual usually is useful by inflating the bag during irrigation aspiration. You don't have to insist to remove this cortical material until you are at the end, making sure that the capsular bag is fixed. Here I had to use this Sayoni ring, but actually I didn't need to suture it. And then I opted to use a 3-piece lens, which is my preferred type in such cases, to implant it in the bag, and it will act like extra capsular support. Of course, you can do capsular capture if you are not sure that this capsule is going to persist in place. So this is a congenital Marfan syndrome. It's a child. So here I'll change the plan. Again, the decentration is big. The zonulisis is 180 degrees. You have to make a small capsular rexes, careful with these elastic capsules in children, and preparing Hoffman pocket, because I was anticipating I might need scleral fixation, at least of one haptic. Here I am inserting early the capsule tension ring, which usually I prefer to implant it later on, as Dr. Muscat said, but here I felt I need to see and evaluate how this bag is going to be centered. Preparing the capsular hook will help me to center better the lens and fix it during the irrigation aspiration of the contents of the bag. I do a lot of hydration in such cases to loosen the cortex and the nuclear contents, so it will be much easier to remove with least tension on the zonules. The capsular hook gives you much more stability and safety, and always I have to check if there is any vitreous coming from the area of zonulisis. because this will prevent the bag from settling in the proper position, and you can stop the vitrectomy if you need it, and then you can continue your surgery. Here, I'm using a 3-piece lens. This is a sensor lens. And I'm going to support the lens mainly on the whole of the capsular bag, and we will fix only one haptic, the superior haptic. I will fix it in the Hoffman pocket. Because even if this capsule by time contracts, then I have the lens fixed, so I can fix the other haptic. In this case, I opted to fix only one haptic. But I generally never leave a lens in subluxation without suturing or fixing in some way. This is another example of trauma in a young patient, and we can see at the beginning of the surgery that you notice that there is vitreous prolapse. So you have to think what to do. You have to think in a lot of scenarios. First, I have to debulk this vitreous and prolapsing. I cannot go easy from behind because then I cannot clear what is in front of the lens. So with high cutting, low vacuum, dry, I'm removing the vitreous. Here, inadvertent opening, cutting of the iris, and then doing the capsulorhexis that is small, checking the back centration. Then you can see how big is the zonulisis. You check always if there is vitreous or not. And then with very low settings, after hydration of the content, because it's a soft cataract, I remove the nuclear part and then do vitrectomy for the prolapsed vitreous, then irrigation aspiration, carefully bimanual, and implanted a capsule tension ring to fix the lens, the capsule in place. Now I'm enlarging the capsulorhexis. Which is now difficult. Filling the bag at all the time, you have to look and see how the capsule is behaving, where is the edge of the equator of the lens, and try to plan what you are going to do. Always make sure to remove any vitreous prolapsing. Here again, a 3-piece lens is placed in the sulcus. And this is going to be safe because it's not a progressive disease. This is traumatic case. And you can also do capsule capture where you can put the optic in through the capsulorhexis and leave the haptics in the sulcus. So I'm going to share with you an interesting case that although years of working, you learn, I'm sorry because there is a narration, so you can hear it.
Nothing alarming pre-op.
You can see that day it was a regular case. I did not expect anything strange.
I noticed very long insertion on the anterior views.
So you can see here, this was a lady, a mother of a colleague of mine, and it looked on the slit lamp examination. I didn't examine her dilated like this. It's not in my mind, this variation. So it was a straightforward case, immature cataract, 60-something lady, 69. So once I started working, so I noticed this is not normal. It's the insertion of the zonules, as you can see, is extremely anterior. Actually, the clear area is only this part. And to make things more difficult, I nicked during the paracentesis the anterior capsule, but it's still, for me, at this point, my whole challenge was to be able to do a proper capsulorhexis without extending to the periphery. You can see with magnification, you can really see what's happening. So I started my capsulorhexis. I was trying to be careful to be working in a small zone. And you can see that I'm trying to move along this zonular fibers, trying not to extend to the equator, which is a very possible thing to happen. But so far, I'm extremely happy. I managed. I thought this is my only worry. Look here to the zonules, how it is stripping. This is in slow motion, just to see how the zonules are stripping. And so I said, I finished the difficult part. Now I will go for the easy part. Then I started phaco, everything is straightforward. Then I start to see wobbling of the whole lens. Trying to work slowly. Look, the whole bag, once it starts to be debulked, it's moving. I'm removing now the phaco, injecting viscoelastic, but still I'm in denial that I have a real problem. So I already asked to bring me a capsule tension ring, but I'm trying to evaluate what's happening. Now it's epinucleus, or part of the rest of the nucleus and epinucleus, trying to manipulate. You can see here, the whole zonules are stripped. Still, I am in denial. The whole zonules all around is stripped. So it's a bad situation, recommended patient. So I try to do some visco expression and filling the bag again. Still, I don't believe that things are going to get worse. So I tried to do phaco aspiration, which was not a good idea, but it didn't do more harm, but it confirmed that everything is loose now. You can see the whole bag coming. So at this point, I said, I can do nothing except removing everything. Up till this moment, there was no vitreous. The anterior vitreous face was intact. I'm using the capsulorhexis forceps, which is a useful tool to remove particles. And here I have to remove the whole bag. You can see complete zonulisis. Probably if I have thought about it earlier, I knew about it earlier, maybe I would have been better prepared, and maybe this will be something to discuss with the panelists. All this, I'm trying still to save the bag, thinking that something can happen. So, no chance to salvage the bag. I have to remove everything. Checking if there is any vitreous. This is, in my opinion, the best way to check vitreous, to sweep from periphery to the center. For me, this is better than Kinecort, because Kinecort will stain everything. Now I'm doing vitrectomy, high cutting rate, low vacuum. And now I'm thinking, this is not my day. So I will try to constrict the pupil. I said I will use a very sized lens. I asked them to prepare, but I redo dialysis in the periphery and started to bleed, which is again confirming this was not my nicest day. But you have to stay calm, try to tamponade the hemorrhage, and wait for a while, and then clean as much as you can from this vitreous hemorrhage. and then trying to constrict the pupil, which now is kept dilated. I'm trying to pull it so as to release some prostaglandins, helping to constrict it. And now preparing the precise. You know that you have to flip it if you are going to do posterior enclavation. And then the enclavation was difficult because I did not think properly because I was stressed. So I make it easier for me to create a paracentesis and hold it from another place. So as logically and mechanically, it's easier to enclavate the lens. So after some difficulty, I could enclavate the lens. Usually it is not that difficult, but that case was not the best case. And then the lens was well centered. I had to take a suture. But what was interestingly, the vitreous hemorrhage cleared in 10 days, but the intraocular pressure was not controlled. She had high intraocular pressure post-operatively. Actually, immediately after the surgery, I went to look in the literature. I have not seen this. So it's always, you are always learning. And there was not so much reports about longs and nodules that is complete. There is partial longs and nodules, which now, once I started to recognize this, I see it a lot. So I'm careful. And these cases, they usually have increase in intraocular pressure and secondary glaucoma. And this patient actually was intractable glaucoma that had to do glaucoma surgery. So it was an interesting case that one has to know that you always learn. I will stop here just to, I have the other cases, but just to ask Dr. Basket and Vladimir what their opinion about this.
I've never seen one. So they all live in Egypt, I think. Now, most fortunately, I have not seen a case of this nature. It looks similar to true exfoliation of the lens capsule, where you can get, you can be confused in doing the capsulotomy, making sure that you're fully through. And that's where trypan glue helps. But in terms of this long anterior zonule case, I've never seen one. The only thing I might have done a little differently when it was apparent that the zonule on the nasal side was starting to come loose. At that point, if you had put in some capsule support hooks, you probably could have salvaged the bag because you had an intact anterior capsulotomy. So long as you had the capsulotomy intact, you hopefully, had you recognized it, you could have placed capsule support hooks and then a CTR. And then you'd have to suture things, or you know, also faced with the enlarged pupil and the iridodialysis, it probably would have been a more opportune time for Yamani technique, fixate a lens in that fashion. But you were not expecting this. You
yeah, and I just got everything is getting, and you know, bad day, and so I tried to use the easiest, but it was not.
When we call that, I don't know if it makes sense in Egypt, but looking at all the desert behind you, we call that when you get sandbagged.
So
you got sandbagged.
If I'm going to, being aware of this complication, I would be prepared better.
Yeah.
I would maybe prepare a double Sayoni ring to suture it from the beginning, for example, or segment, Ahmed segments, or prepare to use Yamani technique. But I wanted to show this because it's very interesting and I've never seen it before. Now you see it, if I look for it, I see partial more. So
does it have any association with any other physical or ocular conditions?
No, the papers, there was one paper that actually studied these groups of patients as in relation to glaucoma. And they found a genetic correlation that some people are genetically, they develop this syndrome and they almost always get secondary glaucoma. So I'm going to move in a different scenario where you have a complication inside. This was a case that was intumescent, mature. I couldn't examine him properly before because he had Down syndrome. He was 54 years patient. Here very early, I can see that I have zonulisis, like 4 o'clock hours. So I have to think what to do. I did a mistake going out only rapidly, so I lose vitreous. I did anterior vitrectomy. I just am trying to evaluate what to do. Is it to convert to intracapsular? Is it to convert to extracapsular? Or to put a capsule tension ring, capsular hooks? So here I'm checking if there is any vitreous, making sure there is no vitreous. And when I did this, I found that the lens settled properly in place. So as you can see, I lowered very much the infusion height. Everything is working very slow. And I was preparing the capsular hooks. I was preparing the capsule tension ring, but I saw how things will unfold. And it was unfolding very well. So here I found there is, at the end, I will not, up till now, use any capsular tension ring. And here I got out in the proper way. Using flushing of the cortex facilitates its removal, so it's not sticky. I don't increase the zonulisis. And then I decided to use the 3-piece lens as a capsule tension ring in the back, and this patient, and it went properly, it was properly centered. And these manipulations are done under proper filling of the anterior chamber with viscoelastic. Of course, you can again do here capsule capture, but here I use it as a capsule tension ring in the back, and it was well centered. And you have to check at the end also there is no vitreous strands at the area where the zonulisis was there. Then otherwise the lens will never center. Another situation. This is a colleague of mine, younger colleague, that called me during operating. I was operating next room, and she told me, I think this lens is subluxated. So I checked, I went to see, there was the capsular axis a little bit small, so I restained the capsule and enlarged the capsular axis. Still, I'm not aware exactly of the extent of the problem. There was any capsular rupture. I'm here working slowly and checking what's going on. It's obvious that there is zonulisis in this area. Very slowly, carefully. So here I said, this is enough. I cannot continue the phaco. I have to change my strategy. I'm using the capsular hooks, which are perfect to stretch and fix the capsular bag. Then I can continue my phaco in a more comfortable, confident way. Again, everything in the setting is very slow. This is the Neuhan chopper. I use vertical chopping generally. And the vacuum is always built when we do proper occlusion. Then manually implanting a capsule tension ring in the capsular bag. And be careful not to lose it outside the capsular bag because sometimes it's impossible. And then a 1-piece lens, in this case, was implanted in the capsular bag. And the last thing was to remove the capsular hooks, which were extremely useful in such case. So in conclusion, subluxation is a challenge and you need to be prepared to reach the proper outcome. I will run through a few cases of IOL displacement. This is an interesting case, a patient that I did her uneventful surgery and she came next morning, eyes quiet, corneas clear. She said, I don't see well. I dilated her. In the auto-ref, it was high astigmatism. I didn't do any sutures, a small incision. So I wanted to know why. So I dilated the pupil and you see that the lens is tilted like this. So I told her, we have to readmit you to adjust the lens. And you can see, interestingly, sometimes if you're doing fast surgery and you was not careful, and the pupil gets narrow at the end of the surgery, this what happened. Look here, the lens haptic is kinked, tilting the lens. So you go from the same incision, it's next day of the surgery, inject viscoelastic, a lot of viscoelastic in the capsular bag, so as not, while manipulating the haptic, you tear the posterior capsule or you induce zonulisis. So a lot of viscoelastic in front and behind, and carefully try to unfold this kinked haptic. Though it looks very simple, but it's an annoying, dangerous complication. So you have to make sure that when you inject the lens, it's properly placed in the capsular bag. This is another case that was referred. The lens was implanted. You can see here there's large capsule tear, but the tear is in the periphery of the posterior capsule. So part of the lens is inside the vitreous and part of the lens is inside the capsular bag. So the lens was displaced. And obviously it was like 1 month or 6 weeks after surgery, of the primary surgery. So you have to evaluate what's your plan, what type of lens is it. And you should always prepare a standby lens. But here I'm checking the capsular bag, trying to see if I can open it again. You can see injecting viscoelastic to tamponate the vitreous, the opening. And here I'm trying to release this lens from the capsular bag, actually from the vitreous. This is a Kugler hook, which is very useful. The balance here is you want to get the lens out without increasing the opening in the posterior capsule or disrupting the whole bag. So the use of viscoelastic maintains an open spaces as well as protect the cornea. Trying to open the bag to disengage the lens. You can see it's a one-piece lens, but this is with long haptics. So I'm just making sure that it is outside of the opening, and then you can capture the optic in the capsular axis. This is the last case. This is a child that have done surgery a few years earlier, and he came with severe, as you can see, severe phimosis. The whole bag, this lens was implanted in front of the posterior capsule and the anterior capsule, and there was severe phimosis encroaching on the visual axis. So you have to deal with this. You cannot do it with the egg laser. And then you have to think what you are going to do with the intraocular lens. This is the 3-piece lens. So I was preparing to do a Yamani technique because I knew that I will have deficiency in the support of this lens. So the first step was to dislodge the lens. This is actually a 27 gauge. We don't have that 30 gauge thin wall that Vladimir was using. So before dealing with the capsule, I decided to fix the haptics. Although now I learned a lot about the technique more from Vladimir. You can see the whole bag is crumpled here. Sorry. This is the first haptic, extruded. One of the things I learned that Vladimir said, and I learned later on after this, is how you direct the opening of the needle to make it easy to fit the haptic, so as not to break it. You can. Now centering the lens. I have to make an incision in the capsule because it's fibrotic. The occlusome will not eat it easily. Now I will go pars plana. If I do this case again, I will go pars plana with the 23 gauge vitrectomy probe. So I left the part of the capsule in the periphery, but clearing the whole visual axis. So this was one of the uses of Yamani technique and the stage planning of how to deal with complications that you see not only intraoperatively but postoperatively, even after years. So thank you. I think this will finish. Thank you very much for this excellent thing. If you have any comments or do you have any comments, Vladimir, Sam?
Oh, Vladimir is muted, so I'll talk. No, I think we've seen an incredible number of cases. All of us have more experience maybe than we want. These cases are very challenging, but they're also among the most rewarding cases that you will take care of. And you just first have to make a diagnosis, make a careful plan, and make several plans, and then follow them through. I think we've shown a lot of material, and we'll be surely, if the people have questions, we can answer them.
Let's see if there's.
Hi.
Yes, Vladimir, we can hear you. I just want to check where stop sharing. Okay. Questions. Okay, but there is greetings from Belgrade, Serbia, from this side of the world. Thank you. No, this is not a question. It's thank for Vladimir. I'm looking, which is better, anterior to put anterior chamber maintainer or 23 gauge system pars plana using Yamani technique for Vladimir?
Yes, I'm using the thing that vitreoretinal surgeons are using. I don't use the anterior chamber maintainer, but just the trocar that is used for pars plana vitrectomy. I just put it into the anterior chamber through the step incision 23 gauge.
Yes, the question is that would it be helpful to put it in pars plana, the infusion?
Yes, sure. It can be done also, no problem, because most vitreoretinal surgeons are doing that. Important is that we have a positive pressure in the eye. That's the most important thing. I don't think we would have problems with the iris in this case.
I think if it's in the pars plana, it's more out of our way. So irrespective, you must infuse these eyes. There's no question as to that. But I think you, and also part of your planning when you sit down and you say, where are you going to place this and that? I think trocar infusion through the pars plana is absolutely the way to go. But I think you want to put it in a place that's going to be out of your way when you're trying to make your needle passageways.
Do you have specific different measurements in children to pass the Yamani, to plan for the Yamani?
I would say about the infusion, if we put infusion behind, then I think we would have to do total vitrectomy. Otherwise, it could push the vitreous from behind to the front. And if we have a high pressure in front and we're pushing vitreous behind, this is my feeling. In children, I do the same technique, but in all these cases, you have to do the thorough anterior vitrectomy to get rid of vitreous, not to have problems then in the wound or wherever. So I usually use the anterior vitrectomy and triamcinolone to dye the vitreous.
It should be about 2.5 millimeters in children.
Yeah.
2.5 millimeters.
Yeah.
That's true. In children, there is more problem with the optic capture. Young men, about 30 years, and children, they tend to have optic capture. So it's better to go more peripherally. And some people do the iridectomy, peripheral iridectomy. I'm not doing that, but maybe it's a smart thing to do.
Some people are also recommending 2 iridectomies to prevent optic capture. I don't know.
Would you do it? Would you do 2 iridectomies?
Not routinely.
I'm not doing iridectomies yet. Maybe I'll start. I don't know. I'll see.
You started when you have problems or to anticipate problems?
When I anticipate problems with the young men, especially, or maybe also in children. We had optic capture in children, and after a while, this disappeared. But still, in one child, I have a problem in one eye only. So going more behind is better. We went 2.2 and 2.5 in one child, and the other we started with 2.
There is a question from Professor of Pediatric Surgery. She's saying that if we know that in children, and if it is Marfan or similar subluxation, it is a progressive disease. So why we make a hassle to keep the capsule, just remove it and fix it in the lens and Yamani or whatever type. So what is there value to preserve the capsule or not? So long it's going to pacify 100% and it is progressive.
Yes, years ago, in few years, I did 15 cases of the implanting the capsular retention ring, suturing in children, and about 10 years, 8 to 10 years later, all these cases dislocated. So we had to resuture, we had to take it out, things like that. And so from that time on, I was using, as you did, the artisan lens. mostly in front, but sometimes also behind the iris. And now that Yamani is there, the artisan in children is a problem. It's a big wound, and suturing tightly is a problem. Astigmatism is a problem. So sometimes I had to suture, I don't know, okay, 10 sutures to close the wound and not to have a hypotony at the end. So when Yamane came, I started with Yamane, and with this, the trauma to the eye, I feel, is much, much less. And it is really, it has no sense to put the rings in, to put everything, and then wait to pacify, and even dislocate later on. So for me, the Yamane is much better for these children with Marfan syndrome, with ectopic and ectopic lenses.
What's your comment, Dr. Musk?
I don't agree. I think to have the lens inside the capsule bag, not in any contact with uveal tissue, is to be preferred. Now, those lenses came loose because we were using tennoproline in our early experience. I think with Gore-Tex, that's not going to happen. Actually, the tissue grows into the Gore-Tex. So I think the physiologic component of having the IOL inside the capsule bag is worth it to me, the extra surgery involved to try and maintain that bag. Now, it's true, it's a longer surgery. I can't always tell you the success rate of plan A when you say, I want to save this bag, and a 3-year-old Marfan's with, 6-7 clock hours of zonulopathy. But I think if you can preserve that bag, that over the lifetime of that eye, it's probably better. Now, I think the incidence of CME is definitely lower. There is a significant incidence of CME when you have IOLs that are not inside the capsular bag. And I know Yamani had a 1%, but if you take a look at other series, it's much higher. So my preference is to salvage the bag if you can, but I agree with Vladimir. Our early experience was they came loose late, but the reason was we were using the wrong materials. That's my sense.
If I can comment on this. Not the problem was the 10-0 suture, but the problem were we did put just one suture in these children, and the problem were the rest of the zonules. The rest of the zonules degraded, so the suture was still there. So then we would have to suture at least at 2 places at the beginning, so 180 degrees apart, or at 4 places, to be able to keep this lens inside. The second problem is we get the PCO, and in children we will get in 100% PCO. So we have to do YAC. If the child is too small, we cannot do YAC capsulotomy. We have to do the vitrectomy. And then there is the open place, and lens epithelial cells grow on, and they could grow backwards into the vitreous, and maybe later on we would have repeated obscuration of the visual axis. I have a feeling now that Yamane is preferred in my hands, but we will see what will happen in 10 or 20 years. Maybe not me anymore, but somebody will see.
I won't be here.
Well, really, I think we conclude. It was, I think, very useful and valuable, at ease presentations. So I hope everybody that attended really benefited from expertise of 2 great surgeons. So really, thank you for your time, and hope to see you physically soon after this goes away.
Bye-bye.
Bye. Thank you.
Bye-bye.
Thank you.
See you.
Thank you.
Thank you.
Bye.
Stay well all and safe.
Thank you.